whenever they ask you IBS, they're going to ask you IBD. Therefore, in the case form, you have to compare the difference between them. So let me give you just a very, very short video idea of that. Somebody will ask, what is IBS? So IBS, as you can see, is irritable bowel syndrome. Okay. All it means is an absorption, so it's more absorption problem. So that's more absorption problem in the colon. That means you're not being able to absorb things you're supposed to do, and it's a motility issue. So there's problem with the bowel moving, and therefore it affects how you absorb food and how you evacuate food. There is no inflammation. That's the key. You should not see any signs of inflammation. And this is the difference between IBS and IBD. No inflammation at all. Therefore, signs and symptoms which you see in a selected apply, most of the time they are bloating. You get abdominal cramp. And therefore, due to the motility, they are alternating, that is the buzzword, alternating of what? Constipation and diarrhea. That is the key aspect of IBS. There is no inflammation, like I said, so you should not see any inflammation at all. There shouldn't be any inflammation, so no inflammation. And therefore, what? You should not see any fever. And when you check their stool does not have any blood in it. And that is the way the board would trap you, try to trick you. The stool should not have any single blood in it. There may be some mucus, but it's not consistent. There shouldn't be any blood, and the patient should not have any fever. The key thing is bloating, abdominal pain, alternating constipation and diarrhea. Their abdominal pain gets better when they have bowel movement. That is the key. After they move their bowel, they feel much better. That's why we got to keep them going as much as possible. What is the issue with this problem? We have no idea. So risk factors. The risk factors, we think is stress, which overstimulate and make the cholinergic aspect of your bowel go in AWOL. Basically, the cholinergic aspect sometimes will move very fast, sometimes it will slow down. So intermittently it's functioning, and that is the main idea. There is no cure for this, but we can manage your problem. Okay. And so some people think there's a mental aspect of it, so mental health issue, and therefore treatment you can see will be tailored based on what you have. But stress is number one, that play a major role. Sometimes food allergy, okay, can also play a bigger role in terms of the disease process. Based on that, you can see that if you have to manage this patient, it's straightforward, right? If I have to manage you, I just go back to pathophysiology. I know the problem is what? Alternation between abdominal constipation and diarrhea. There's so many factors involved. Therefore, management attack the issue. Number one issue, stress. So stress management. In stress, the board will not tell you stress. They will give you things. They will say, oh, coping skills. That's stress management. They will tell you the patient is doing yoga. That's stress management. We talk about exercise. That's stress management. Walking. That's stress management. That is dancing. You know, things that will at least improve your activity is the management of that. So all those things, it's fine. If it's a mental health, most of them you can use antidepressant and to treat their problem. Okay, so that can also help with that. If it's a food allergy, you avoid it. But like I said, most people does not know what is their problem. And so it's a big problem. So the whole thing you do is a shotgun effect to figure out what you need. Okay. Some people can also do things, we can also do things to change the bowel bacteria in the gut. So if you see a probiotic, that's fine. That also can be used for IBS because it changed the bacteria content in your GI tract. And so it's an adjunct for management. Okay, these are the common triggers. So triggers, and therefore they should avoid it. So any gas forming food, they should not eat it. And you know that if you think about what you do for colostomy, it's the same thing. Cabbage, too much gas, right? Banana, too much gas. Okay, broccoli, too much gas. They should avoid it as much as possible. Beans, they give you too much gas. They should not eat it. Onion, they should not eat it. It's too much gas. These are all bad stuff for them. They should also avoid irritants. I call them the cats. Irritants, these are never good things, right? Caffeine, yeah. Alcohol, tobacco, and spicy food. So they should avoid all these things because they are irritants. They cause problem for them. So these are food they should try as much as possible to avoid it. That's the next thing you should teach them about it. Then there's food. We call it FODMAP. It's a big name, but it's just simple thing. Basically, we call them fermented, one, oligo, monosaccharides. Basically, these are group, the fourth one, that's what I've written, fermented monosaccharide. It's a group of food that we tell people to avoid. So they should avoid these kind of food. So there's a class, you can list all of them, but put them together. Food that has a syrup in it, yeah, they should avoid it. That's one of them. Food that has fructose, too much fructose in it. Okay, and then it has a honey in it and wheat. Okay, those are the four group of food that you avoid in terms of FODMAP. And you can see you can find this in a bunch of food item. Everything you drink, soda, cereal, or anything like that is one of these things in it. So they have to have a food diary to avoid being get into trouble with that. This is what you tell them. The other ones is dairy product, but it's not part of the FODMAP. But these are also things we tell them to avoid: dairy product and high fatty food. They should not eat it. So these are most of the teaching is all related to food and food and food and food. Okay. So now, then what can they eat? Okay to eat this stuff. Okay, it's okay to eat these ones. What food can they eat? I just convert the FODMAP and I turn it into two. So I'll say low FODMAP diet. So things that's very low syrup, no fructose, no wheat, or no low amount of it. Honey, yeah, very low amount. They cannot just avoid it, but low amount. So they should low FODMAP diet. For the FODMAP diet, we use low amount for that as much as possible. What is good for them is high fiber. So they need to improve their fiber diet, okay, like grain and legumes, fruits, nuts, vegetables is also good for them. And then they need to have like high protein, okay, because of the absorption and the blended diet is good for them, okay? Remember There's two types of IBS. Sometimes, I don't know, your board can confuse you with that. Don't worry about it. There's IBS C and IBS D. What do you mean? The C means constipation. And the D means diarrhea. That means there are people who most of their symptoms are diarrhea, most of the symptoms are constipation. So you have to tailor the treatment to that. If it's mostly constipation, yeah, these goods are good for them. This food is also good. If it's diarrhea, then you have to make sure you try to make your stool more bulky, so slow them down. And so in terms of pharmacology, all of them, all of them will take dicyclomine. This is an anticholinergic, and that is the treatment for IBS. It's the most common. It can treat both diarrhea and constipation. All it does is it's anticholinergic, so it slows down the GI tract and then prevent overactivation of the cholinergic. Of course, you have to know side effect of anticholinergic, right? Urinary retention, so low urine output, okay? Secretion go down, so dry mouth, right? And then the bowel, GI tract slow down. And then the most bad complication is a glaucoma. It's going to worsen your glaucoma. So it causes this dilation. So if the patient has glaucoma, you should avoid it. Like I said, dicyclomine can be used for both diarrhea and constipation. For mostly diarrhea, you can use Imodium, loperamide. So that's the most common one that you can use, loperamide, to help with this constipation, basically to slow down the diarrhea and make the individual more constipated and help with their symptoms. This is what IBS means, irritable bowel syndrome. Know the different types, what you should avoid. Know that there's no infection. There's no signs of infection, no fever, no temperature, no blood in the stool. There should be no blood in the stool. That's alternating constipation and diarrhea in the management of this patient. And that is all. And food they should avoid, food they should eat. If you get a case like that, it can also confuse this with celiac disease that we're talking about, IBS and IBD. Okay, so that is the first portion of it. Now, IBD, inflammatory, you see, is inflammatory bowel disease. That means inflammation. There is inflammation is the key. What is the problem? This is an autoimmune disease. Your body is fighting against you. Body basically fighting against you, doing things it's not supposed to do. And so it's bad problem. Your body itself destroying you. So this has both, it's a chronic problem, and it has both alternating and symptoms back and forth. You have recurrent infection going on. So that is the big difference. Okay. Chronic inflammation, that never goes away. Chronic inflammation. The key thing is IBD, there's two types. There's the Crohn's, this is ulcerative colitis. So you have to know the difference. And then in order to do that, I'm going to draw a table and then we talk about it so that it makes it easy. So I'll put Crohn's here like that, and I'll give the difference. This is Crohn's. Crohn's disease, number one, is what? This is a full thickness problem. Full thickness, that's the whole bowel. All the layers of the bowel affected. That is the difference. Ulcerative colitis is just the mucosa. That means the inner lining. So let me draw a diagram for you and see, show you. So if this is the bowel, and these are all the layers of the bowel, for Crohn's disease, what is going to happen is all these layers is affected. In ulcerative colitis, if this is the bowel, with all the layers, the difference is ulcerative colitis, it's just the mucosa is affected. That's all. Based on that, you can figure out the symptoms they're both going to show. For Crohn's disease, they're going to have diarrhea, yes, but minimum blood. So there is no bloody diarrhea. These people, bloody, it's all blood, pure blood. So when they give you a case and you see bloody diarrhea, know that it has to be ulcerative colitis when we're talking about inflammatory bowel disease. This is bloody diarrhea and that. Because of the full thickness nature of this, number 3, you can have fissures, you can have fistulas, you can have abscesses, okay, you can have stricture. For ulcerative colitis, none of them. You don't get fissure, is in the anal area, there's a cut, fistula, things are sticking to each other, abscess, bad infection, perforation, and stricture, you get an obstruction. And therefore, when they give you a question and they say the individual has obstruction from IBS or IBD, know that it's mostly Crohn's disease. It's mostly Crohn's disease, but it's not ulcerative colitis. So this has obstruction. Obstruction here, not. Okay, so that's another big problem. These are the way you can find the difference. Of course, all of them, they're losing and they're having diarrhea, they cannot absorb food, all these problems, they're both going to have what? Weight loss. They're going to have weight loss, they're going to have more nutrition. So this is the same. In terms of anemia, less anemia here, but still anemia compared to this is more anemia because they having more bloody bowel movement. So I'm trying to give you the difference between them. So let's turn this one. So that's the difference between the first portion. Now, let's do that again. So this is Crohn's. This is UC. So the other thing too about this is the Crohn's disease is if this is the bowel, and this is the bowel for Crohn's, and this is the UC. What you're going to see for Crohn's is a skip generation. You have Crohn's disease here, then you get, there's a normal bowel, you see it's Crohn's disease here, then you see a Crohn's disease. In ulcerative colitis, it's continuous all over. There's no skip degeneration. So this is skip disease. So you have a skip disease. There is no skip disease in ulcerative colitis. The other thing too is for Crohn's, it can involve from any layer. So from your mouth to your ends. That's for Crohn's. So any layer of your GI tract is affected. For UC, you just start from the rectum to the large bowel, to the cecum. Okay, large bowel. So the colon, basically, mostly the colon and the rectum. How about that? Colon and the rectum is affected. Rarely do you see it in the small bowel. So that is the big difference. So all layers from your mouth to the anus is Crohn's. UC is just the rectum and the colon. That is the big difference. Okay. Both of them, they're going to have skin, your eyes, and joint problem. Both. This is for both. So they can have extra skin, extra intestinal manifestation related to the skin, the eyes, the joints. And so those three things, if you see in the question, yeah, that is fine. This is the difference between Crohn's and UC. They are inflammatory bowel disease, but the layers involved, the kind of diarrhea they have, what they form, strictures, which bowel is involved, amount of anemia, which colon, whether you have skip generations, and then skip lesions, and they both have eye and joint problem. One summary for all the two of them. Okay, so this is something you have to know. They put in the table form, and you have to figure out what is going to have. Both of them are going to have weight loss, more nutrition, and other things. Okay, so now, in terms of risk factors, this is family history. That one, you cannot change it. But other modifying risk factors, it may be related to NSAID use, smoking, where you located, location. These can affect it, okay? But it's an autoimmune disease. How do you diagnose this? Usually colonoscopy with biopsy, okay? That is the way. You have to do colonoscopy. You come in with those symptoms, but we have to do colonoscopy to biopsy to figure out what is the problem. What is the complication for this? The major complication is because of the recurrent infection, inflammation, recurrent infection, there's a risk of cancer, okay? Of course, you saw malnutrition. You can also have chronic anemia, growth retardation, especially with Crohn's. And then they can have recurrent infection, so they can have C. diff infection. It can also be a problem for these people. Okay, then you have to know this. Of course, they're going to come in acute problem. They're going to have acute infection. How are they going to present? They're going to have abdominal pain, diarrhea, fever. Their white count will be elevated. They look sick, all the things, and they have bloody diarrhea. If it's ulcerative colitis, if it's Crohn's, they will have obstruction. So depending on which one it is, then you got to figure out management, acute management. It's a GI problem. This should not be that. You know what to do when it comes to GI problem. Everybody who is having these symptoms, abdominal pain, fever, all those things, do you think they want to eat? No. Make them NPO. If I'm NPO, I cannot eat, give me IV fluid. If I have pain, manage my pain. Okay? All these things. Because I cannot eat, sometimes this lasts for a couple of days, 5, 6 days, they may need TPN, right? If they're vomiting, yeah. They may need NG2, but most of them, they don't need NG2, okay? Then you got to make a diagnosis. First, you got to make sure it's not some viral infection or C. diff, so they get a stool culture. You will need antibiotic, okay? And then what do? You just give them high dose steroid because it's an inflammatory process. So high dose steroid to take away the inflammatory process. You need to give them journal to write about their feeling. This will help with the stress and calm down their GI tract. Okay, this is the acute problem. When they starting getting better, when you want to give them food, yeah, you got it. There's ways you can treat them in the acute. After that, after they've gone through this past area, there's things you can do to minimize recurrent infection. But before that, it's pharmacology associated with it. These patients, they need treatment. Most of the time, they need maintenance treatment. So let me clean this. They need medication. The steroid is for short-term use because you cannot be on it for a long time. Steroid is a short-term. This is for steroid. You can use it for a long time. But the most common medication we use them is we have a topical form, which are the salicylate. So we have amino salicylate. Okay. These are the 5 ASA. It's like aspirin derivative. You've seen it before. Mesalamine or sulfasalazine. Remember, these are sulfasalazine is a sulfur drug. So the B sharp moment is Stephen Johnson. I'm just trying to bring something you probably know. When you're studying, this is the way you do. As soon as you see something, you think, I know, hey, yeah, I know this. So what would I want to do? Yeah. You see sulfasalazine, they're going to have photosensitivity. Okay. Sulfur drug, let them drink IV fluid to prevent stone formation. The most serious complication is Stephen Johnson syndrome. This is a B sharp moment, and they're going to have small purple rash in their chest, and then you know they are in trouble. That's when you see them. It's a big sharp moment. Okay, so that's what you give them. But the biggest medication that they use most of the time is infliximab. Infliximab. Adalimumab. These you can see, they have the last name mab at the end. They are immunosuppression. So you know this already. These are immunosuppression medications. So what do you think? They are bad. Before we start this, we got to do a TB test and then check for hepatitis. If they have any of them, we can start it, but TB is number 1. If you have PPD positive, you cannot take this medication. So check for PPD. When it's PPD positive, we shouldn't give them this medication because then that will make them sick. It will activate PPD that has been dormant for a long time. They will develop active TB. So if PPD positive, don't give them. So the question would be, what do you do before starting infliximab or adalimumab? Yeah, check PPD. Or you can do hepatitis. But the most common one is PPD is the most important one. So you check that. When they're on this therapy, what should they avoid? Avoid live vaccines. They should avoid all live vaccines when you're taking this medication as much as possible. And they should make sure they're getting influenza vaccine daily. They're getting vaccine daily, and then neutropenic precaution, basically. Okay, so that's for that one. After they get better, what do you recommend? Okay, post-acute, yeah, they need like high protein diet because the absorption problem, but this has to be small meal at the time. Then low-fat diet to prevent trigger. They will need some vitamins and minerals to replace whatever they're losing. Okay, they will have small frequent meal. As soon as small frequent meal is good for them. Okay, because of the diarrhea, they need 2 to 3 liters of water a day, as much as possible. Smoking, stop smoking. And avoid NSAID as much as possible. When they have a diarrhea, they will develop hemorrhoids. And so you can use like a wipe, skin barrier to prevent irritation of the anal area as much as possible. Okay. Of course, avoid triggers like caffeine, alcohol, and all these things. So this is what you tell them. to do as much as possible. Okay, the diet should also contain like low fiber when they're progressing from the acute phase. Sometimes they will give you this problem. You can have something we call toxic megacolon. This is like severe form of the IB, mostly UC or Crohn's, but mostly UC, they have toxic megacolon. That means their colon become really, really dilated. It get bigger and bigger and bigger, very big, greater than 6 centimeters. Okay, they will have fever. They will have hypotension. You will have tachycardia. You see? And all of a sudden, the buzzword you're looking for is sudden cessation of their diarrhea because the bowel doesn't work anymore. You can't move the stool out. So sudden cessation of diarrhea, fever, hypotension, tachycardia is what we call toxic megacolon. That means the colon is very sick. This is an emergency. You got to make them MPO right away. They may need IV fluid, TPN, high-dose steroid, and you watch them 3 to 4 days. If nothing happens, they get surgery. This is everything about ulcerative colitis and Crohn's disease, and the difference between them, and then that of irritable bowel syndrome. One thing before I go, Crohn's disease, no cure. We do surgery for symptoms when you have symptoms to cure, to resect some bowel and help with the problem if you have obstruction or other thing. UC, ulcerative colitis, there is cure. And usually you need colectomy. We got to remove all your colon, and then you'll be cured the rest of your life for the disease. And you don't need all those medications. But Crohn's disease, you don't. There's no cure for that. This is a short video for IBS, IBD, with the IBD talking about Crohn's disease and UC. Take care of yourself. If you don't subscribe to the channel. If you want more content like that, join our membership. Very cheap, one of the cheapest on YouTube. And you get good content, master your NCLEX. All the best of luck and good luck. Bye-bye.